All right. So I just wanted to give a little bit of background on this sort of tutorials. Essentially, Josh, who you will see on your screen, Josh is my resident who I've been supervising for the last year as a resident, but before that as an intern, and then following his career closely as a GP because he's such a brilliant medicine mind. I pick on Josh heavily because we've got this sort of background and I ask him a lot of questions and things like that. But anybody coming for the first time, don't feel like I'm going to do that to you. I'll always ask for your consent before I ask you questions directly in a group setting. But Josh loves it, so he says. And then we've had a lot of attendees coming for a long time, and I'll introduce Jeff as well, who contributes a lot. Jeff is a medicine specialist from way back, and he brings a lot of experience to the discussions. We try and keep these as interactive as possible, but we're essentially working our way through Edinger, and some of the subjects just really they're not very interesting. And so those ones we tend to do in a case-based sort of format, and then sometimes we go pretty deep in physiology. So come to the sessions you want to come to. If you can't attend, they'll be recorded and they'll be loaded up a link will be loaded up on the website. We've got a YouTube channel that you can go to and access all of them. So we might as well get started. So the theme today was oral and esophageal disease from the Edinger textbooks. Did anybody have a read? Nope. Josh, you have to nod, just pretend. Yeah, good. So I went back to my fellowship notes from these chapters and it literally says waste of time, don't bother. Sorry. So I'm glad you didn't put too much time into the reading. So they talked a lot about the different sorts of neoplasias that we see in the oral cavity. They didn't even mention some of the salivary diseases that would have fallen into this category, I thought. And certainly the discussion around diseases like megaesophagus and esophagitis and things that I think are really, we see them so commonly. The discussion was really minimal. So I thought we'd just do this kind of case-based for today and just work through some kind of cases and differentials for different presentations that kind of localize to the oral, pharyngeal and esophageal regions. Is that all right? Keep it a bit light. Okay, so we have a 2-year-old cat who presents with a 2-month progressive reduction in appetite, went off dry bickies first and now has gone off wet food, and has lost around about 1 kilo since last checked 6 months ago. The owner mentioned that she's frequently wiping around the mouth because there's been excess salivation noted. On your physical exam, you notice there's a very diffuse stomatitis, particularly surrounding the teeth caudal to the canines. What are you going to do? I mean, this is something we see so often clinically, but as a medicine specialist, I never see it. So this was something that was sort of interesting for me to read about.
I would run, oh, sorry.
Sorry, Bron, what was that?
I was just going to say I would run a full biochem and CBC panel, and then if everything was normal, do dental radiographs and a dental probing and examination.
Excellent.
Yeah, I always used to do that too, but urinalysis are always.
Yeah, absolutely, particularly for those people sitting exams, biochem, hematology, urinalysis, they're the 3.
And retroviral testing.
Yeah.
Oh, yeah.
Good. Excellent. That was my add-on to that. So I'd probably do that before doing anything that involved an anaesthesia or invasive. If you're taking blood anyway, I'd add on FIB, FELB testing. Why?
Because it's been associated with proliferative gingivitis.
Yeah, absolutely. So particularly the whole mouth stomatitis. What's the cause of the stomatitis? What's the sort of thinking behind why it happens?
I think it's an aberrant response to plaque, a hypersensitivity to plaque.
Yeah, what's plaque?
Combination of bacteria and biofilm on the teeth.
Exactly right. So it's essentially a hypersensitivity to normal oropharyngeal organisms. So where plaque is an amplification of those organisms, it still shouldn't cause the degree of stomatitis that we see in this sort of, very pathologic presentation where the whole mouth is affected. So its origin is in immune dysregulation, so an inappropriate immune response or hypersensitivity to bacteria in the mouth. So FIV in particular is very closely associated with stomatitis, and the treatment's quite different as well. So there's a really good article in JFMS, the Journal of Feline Medicine and Surgery, which is a kind of consensus statement on the management of FIV-associated diseases, but stomatitis in particular. They've got this beautiful box, this is what you do. And the main difference is that often we're using glucocorticoids in cats with stomatitis. If they have FIV, you don't want to use glucocorticoids. It's probably going to make it worse. Or it's going to decrease inflammation and make them eat again, but it's not going to fix the underlying problem. Good, excellent. So then we've ruled out FIV, FELV. That was normal on our blood test. Our biochem was normal. Our hematology showed a mild increase in eosinophils. And other than that, it was normal. What's the significance of the eosinophils with oral lesions? What's one of our other differentials other than just kind of stomatitis?
Eosinophilic granuloma.
Yeah, absolutely. And
Yep.
obviously,
Yeah. That might be worth chasing as heartworm, but it'd be really rare.
yeah, absolutely. Particularly with the distribution I've described. Like you can kind of pattern recognize these. What does the eosinophilic granuloma complex look like?
Right, like raised plaque type lesions. Generally.
Yeah, usually. And where do they normally sit?
I think like on the back of the tongue and kind of oropharynx.
Yeah, absolutely. So the base of the tongue is the most common place that we see them. The other place is those indolent ulcers that are on the margin of the lip. Have you seen them? Rodent ulcers?
Maybe GP, I can't remember.
Yeah, it's been too long.
Occasionally they'll present bleeding from an ulcer on the roof of the mouth.
The palatine vein ones.
Palatine arteries.
Palatine artery ones, yeah.
Yeah, so that's quite spectacular. So we've seen cats with really severe anemia. I have to say that since the flea products have come a long way in cats, we're seeing less, in my opinion. Does anybody agree with that? I haven't seen any.
Definitely, yeah. I haven't seen one for ages.
And I've probably made a link there that doesn't exist with the flea products, but certainly hypersensitivity to parasites is one of the etiologies of eosinophilic granuloma. But we used to, when I was at North Shore doing my training program, we used to see cats with really severe bleeding, presenting with melena and anemia, and they had this ulcer in the roof of their mouth that had eroded through the wall of the palatine artery. And they were getting spectacular blood loss and just swallowing it. You know what cats do. They just hide everything. So that's one of the differentials of melena in a cat. Always do a thorough oral exam for sure. Going back to infectious diseases that might be associated with stomatitis, FIV, FELV for sure. What are the other viral diseases we should have on our radar?
Felici?
Yeah, excellent. And where distribution-wise, I've described very much stomatitis hugging the teeth, but localization-wise, if you're doing an oral exam and you see stomatitis that's not necessarily periodontal, where would you expect it to be associated with colici?
No, eyes as well. Is that where they get the
that
Keratitis and
absolutely,
conjunctivitis.
absolutely can do, but actually more are talking about the ulceration, like where you see it within the mouth.
Oh, right, sorry.
It tends not to be near the teeth with colici. So say again, Sam.
On the tongue?
Excellent. Or where are the tongues?
Margin?
They can do. That's a really good point, actually. So there's two forms of colici. There's the oropharyngeal colici, like localized colici, and then there's also systemic colici. And with systemic colici, they get really profound inflammation, and they get tongue tip necrosis and tongue periphery ulceration. So where all the antigen antibody complexes are depositing in the tiny, tiny vessels that right at the tip, right at the extremities. But with the local colici that we actually see quite commonly, so just capillary colici, they get ulceration of the palatoglossal folds. Is that the word? Yes, the fold that goes down from the palate to the base of the tongue.
Okay.
It's a really localized inflammation. Obviously, this is, you know, your cats are never like doing exactly what the textbook says they should do, but you can get a hint of what might be the etiology. And in that situation, I potentially, you know, if I was doing an oral exam and had a sedated cat, I'd probably take the opportunity to do a swab of that region and submit it for viral PCR, so the respiratory PCR, which will test us for colici. What about other infectious causes that aren't viral? What about immunosuppressed cats? What might they get overgrowth of in their mouth? It's not bacteria.
Maybe candida.
Yes, good, absolutely. So particularly cats on IBD meds and, you know, immunosuppressed for other reasons, history of immune-mediated disease, certainly worth swabbing and doing cytology for candida, overgrowth of candida in the mouth. And interestingly, stomatitis is associated with way more Pasteurella than in a normal mouth. So they don't know whether that's cause or effect, but it's just an interesting, I mean, if you did a culture of a mouth, you're going to grow Pasteurella, it's going to be hard to quantify, but it's just an interesting etiologic note. So how are you going to treat it? It's stomatitis, this one's stomatitis, and there's no viral association that we've identified.
Richard Malik used to talk about anaesthetising them and painting them with Bonjela, which I've tried a few times, and I won't make any comment really because I don't know whether it helps or not.
There was so some bell ringing about Bonjela and cats, and I feel like there might be a contraindication for it, but that's it. It's not one of my treatment options. When it's really periodontal, what's the thing that's sort of most effective to decrease?
Well, scale the teeth.
Yeah.
And I think the really bad ones, people have ended up doing a total dental extractions, take all the teeth out.
Absolutely. Yeah, so whole mouth extractions. And certainly I don't follow the dentistry journals, but whole mouth extractions are the only thing that's been shown to result in complete resolution of the stomatitis, because you're always going to have bacteria in that gingival margin while you've got, like, you know, a tooth meeting the gum. Whereas if you've just got a smooth surface, you're never going to get that collection of bacteria at that level in that location. So do you take out all the teeth or do you leave any?
Or
Take out the premolars and the molars and leave the others if they're not affected, and take them out if there's ongoing inflammation.
Yeah. The most recent data I've seen says to remove the teeth caudal to the canines. So you leave the canines and the incisors and take out the back ones. And that will result in resolution of 60 to 70% of cats. So obviously, you know, this is a massive thing for owners to commit to financially, for the cat to go through clinically, and everybody needs to be on board that this might not solve the problem. Say the cat was FIV positive. What other treatment options might we have?
Antivirals. I don't know which ones you use because I've never seen it.
Yeah. God, I always get the names wrong. They call it AZT, which really throws me because it's zidovudine is the actual name. So I don't know why in all of the papers I'm like, oh, that's azathioprine. You don't give that to cats. Why are you talking about azathioprine? But it's not. It's zidovudine. I can't remember what its trade name is. But antivirals have been shown to make a difference in stomatitis in FIV positive cats. Anything else?
I'm not sure if you can do like dietary changes or go down the path of things like probiotics.
Yeah.
But yeah, I'm not sure.
I really love that concept. So we know that giving oral probiotics changes the oropharyngeal flora. We don't have enough data because our use and study of probiotics is so early. We don't have enough data to have demonstrated benefit in disease states. But certainly with things like chronic cough in dogs, things like probiotics have been shown to be beneficial because you change the oropharyngeal flora to be not so pathogenic, and the little bits of bacteria that do get breathed in every time you breathe in are less pathogenic and therefore less inflammatory and therefore contribute to cough less. So I really like the idea of probiotics, but I don't have evidence to support that in stomatitis. What about other immunomodulators? So we sort of talked about cortisone, but if FIV positive, we're not going to do that.
Doxycycline?
Doxycycline, yeah. How's that sit with your antimicrobial stewardship?
Not great. Not great.
It'll work though. It's just not a long-term solution, unfortunately. I mean, you don't want cats to be on doxycycline long-term. I think it's worth a treatment trial to document response before you do the whole mouth extraction. So if you document that decreasing the bacterial load improves the stomatitis, then you can take the teeth out to decrease the bacterial load and have the same effect. So it sort of helps you to justify, to predict your response to a whole mouth extraction. What about other immunomodulators other than doxycycline?
Cyclosporine.
You could use cyclosporine, yeah. What are the downsides of cyclosporine in cats? The main one, so you know how you have a case that goes badly and then it burns you and then you're scared of a drug for the rest of your life? Cyclosporine is one of mine with cats. They're really immunosuppressed by it. And obviously this is a risk for any patient on cyclosporine. That's the idea of the cyclosporine. But I had a cat that developed a pancreatic abscess and died of septicemia on cyclosporine for inflammatory bowel disease, pancreatitis and cholangitis because we hadn't been able to get on top of it with pred. So it's one of those medications I think, maybe cats are more severely affected. Maybe this cat was more severely affected. You just don't know. But it's absolutely well documented. What's another immunosuppressant that we use quite commonly, particularly in IBD and gastrointestinal disorders? It's a chemo drug.
Yeah, Chlorambissal.
Yeah, excellent. Yep. So Chlorambissal is an immunosuppressant. It's generally really well tolerated, but it is in the chemo kind of class of drugs, and therefore I think there's just a barrier to people using it a lot of the time, but it's a very effective immunosuppressant in cats. We use quite commonly with a lot of different immune-mediated diseases.
Are you talking about using this in FIV positive cats where your antiviral hasn't worked, or in where it's not FIV and extraction hasn't worked, or both?
sorry, what was that? Using like Chlorambissal and stuff?
Yeah,
In the non-FIV cats.
non-FIV. Okay.
Yeah, exactly. Yeah. Because the FIV cats, the mechanism is a little bit different. It's probably not a hypersensitivity. It's probably actually an overgrowth of organisms and an alteration in their normal kind of immune responses. So they're more likely to, decreasing the viral load will regulate their immune response. That's kind of the target. There's another immunomodulator, the interferon. Has anybody heard of the interferon? So there's a interferon omega, feline interferon omega, that can be used subcutaneously, which has been shown to improve stomatitis. And there's a human oral interferon, which can also be used but doesn't have as much evidence behind it. But both are hard to get. And the feline in particular one, I think it's like $800 a box or something. Like, it's quite cost prohibitive, so not many people go for it. But worth looking into if you've kind of tried everything else, and cost isn't an issue. Okay, does anybody have any questions about stomatitis or that case? Excellent. All right, let's move on to a 4-year-old dog who was previously very active until 2 days ago, when developed acute onset retching, gagging, and vomiting, true vomiting, and regurgitation, combination of vomiting and regurgitation. Very acute onset 2 days ago. What more historical information do you want to know?
Tick control.
Excellent. Yeah, up to date with Bravecto.
Yeah. The food, because of the one we spoke about last week. Yeah.
What did we talk about last week? Sorry, Jeff.
Yeah, was causing macroesophagus in.
Oh, that's right. Yes. Like, so a neuropathy, myopathy. So really good. So screening for causes of maybe megaesophagus or laryngeal paralysis. Excellent.
Well, myasthenic gravis might be another option.
Absolutely.
Secondary.
Absolutely. Good. Any other historical, very sudden onset with this dog?
Yeah.
Any access to toxins or?
No, very safe. Shed's always locked.
No renovations at home, that kind of thing?
No.
Is it a dog that chews on things?
It is, yeah. It's a really naughty boy, and we give it a bone every day.
So I don't think a gastric tumour would be very likely at that age, but it shouldn't be ruled out until proven otherwise.
Absolutely. So physical examination is quite normal, but the dog doesn't like you palpating around its neck. When you do an oral examination is normal, but the dog is just going bleh, 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 the whole time you're looking at it. You do a trial feed because the owner says he's been eating okay, but he is retching kind of between mouthfuls and things. And often, like, he's got a good appetite, but he's bringing up sort of bits of the meal. Some of it seems to go down, some of it doesn't. And then he's also doing this true vomiting, where he's sort of retching and then bringing up everything he actually got down. So you do a feeding trial, and it's exactly as the owner's described. The dog seems to be able to get food into its stomach, but that certainly things passing through the pharynx and esophagus is triggering these retching regurgitation episodes. What do you do next?
CBC biochemistry, urinalysis,
Thank you.
and thoracic radiographs. That's what I'm going to do.
Yes, exactly. Good. Okay, I'm going to share my screen. Ooh, am I am. You do your thoracic radiographs. Can you see that okay?
Yeah.
Excellent. What do you think?
I'd like to see it in like a pharyngeal radiograph.
Yeah.
Yeah.
I can't see.
So glad you said that.
Yeah.
What do you think?
Looks normal to me.
Yeah. It looks nothing very exciting.
Oh, dear me. That's not right. Ew.
Whoops.
What's that?
Is it?
Oh, is that not normal? I thought it was part of the larynx.
No.
Well, it's a bone opacity, so if it's not meant to be there, I guess it's dorsal to or it seems outside of the trachea, so I'd be worried about a foreign body in this upper esophagus.
I would also be worried about foreign body. So the hyoid, you can see through here, and that apparatus is separate from that part, but that's literally stuck just beyond the larynx. Like, it's really cranial. So I'm so impressed with you guys for saying I want to see a pharyngeal radiograph, because so often proximal esophageal foreign bodies get missed because it's really hard to keep a dog's head still and radiograph the top of the esophagus, particularly in a retching, regurgitating dog. It's difficult to sedate them. You're worried about it. You end up.
2 microchips, Jeff.
But you had it?
2 of them by the look of it.
2 microchips.
It's so well loved. Identified twice. Okay, what are you going to do about this?
Scope it, I think, would be the best thing to do.
Yeah, absolutely. It's probably proximal enough that you could see it with a laryngoscope and grab it. It's going to be a really hard location to do with an endoscope. You're not going to get insufflation in that spot because it looks like it's right at the upper esophageal sphincter. So in this situation, I'd probably push it down to then be able to inflate, see it, grab it without grabbing mucosa and stuff, or try and do it with just a laryngoscope visualization. So I think it's going to be sticking right up just dorsal to the larynx.
Well, what they used to do at the Angel Memorial is to get a stiff polythene pipe with the edges rounded and softened.
Yeah.
Sort of bigger than and it's amazing just how big a pipe you can get down a dog's esophagus.
It's amazing, isn't it?
And push it just beyond the, or just, to and over the foreign body.
Yeah.
And put your scope down through there so that you can see.
Mm-hmm.
And then you grab it and pull it up into the pipe. So the pipe at least will keep the esophagus away from the foreign body as you remove it.
Yeah, exactly. So you don't traumatize the esophagus when you're dragging this foreign body out. So the pipe serves a really nice purpose in that it expands the esophagus off the foreign body. So I really like that technique for things like sharp foreign bodies in particular. So this looks like a really sharp little fragment of bone, and you can see that it's a stick of bone. The food's going to move around it. The water's going to move around it. This dog can be getting things into its stomach, but it's definitely going to be causing irritation in that area. My experience is that proximal esophageal and laryngeal, pharyngeal foreign body injuries cause so many more clinical signs than a distal esophageal foreign body injury. So there must be so many more kind of gag receptors and things in that region than in the distal esophagus. Because a lot of distal esophageal foreign bodies, they kind of bring up frothy saliva and whatever they've eaten. But they're not just retching consistently and really upset by it. Why is this dog vomiting? True vomiting.
Just going to ask the same question.
It's a good one.
Does
I'm going to guess there's a reflex that's initiated by the irritation.
Yeah, excellent. What's the sensory nerve to that region?
Vagal. Oh wait, no.
Vagal, it probably actually, you're probably right. Where that bone is sitting now is probably vagal, but what about in the pharynx?
Glossopharyngeal.
Good. And this is a silly question, but where's the glossopharyngeal nucleus in the
So, you mean like brain stem?
brain stem?
Oh no,
Yep.
I'm confused. Yeah.
Great.
Great.
I haven't worded the question well at all. You're never going to get the answer I want you to say, so I'll just tell you. The glossopharyngeal nucleus sits right next door to the vomiting centre. So when you get a lot of stimulation of the glossopharyngeal nucleus, you get this overflow stimulation of the vomiting centre. So it's not uncommon with retropharyngeal stick injuries, foreign bodies across the pharynx to get true vomiting with retching and bringing up stomach contents because of that gag reflex. You know,
Anna,
yeah.
is that the reason we can make ourselves vomit with the finger down the throat, literally?
Exactly. Yeah.
Ah.
Yeah. So triggering, that's what you're doing when, you know, people are inducing vomiting in themselves. That's what you're doing, is triggering the glossopharyngeal nucleus, and that triggers the vomiting nucleus.
Cool.
I should say it's not a nucleus. Excellent. Okay, what else do we want to talk about? Let's talk about this. So 4-month-old dog comes in and the owner is saying something's wrong with my dog's mouth. What's wrong with this dog?
Oral papillomatosis.
Thank you, Jeff. Could everybody answer that, just out of interest?
I've had a lot of those lately.
Oh, have you?
Yeah. I don't know if it's because I've got a lot of immunosuppressed patients at the moment that are puppies, but or if it's just going around or something. But
yeah, they're just licking each other.
Yeah.
Yeah, they're all hanging out at the same dog park. You've got an egg on your hands.
Yeah.
So I put this in because this was actually a fellowship question. What's this? And many of the candidates, particularly the ones that went straight from uni into specialty practice, have never seen it. So that's exactly what it is. You don't need to know any more about it than that. It'll go away. Don't do anything about it. It's just gross in the meantime. And I nearly put, when I was looking for these pictures, there was this pug with florid papillomatosis, and it was all over its face, all through its mouth. It was the most spectacular picture, but I thought that's probably a bit obvious and will gross people out. They won't be able to concentrate. Okay, so you've got a 10-year-old dog who presents with the owner having noticed this oral mass. And the dog's having a little bit of trouble with prehension and picking up its dry food and chewing its dry food with this mass. When you see a mass like this in a dog's mouth, do you have a differential list in an older dog that you'd be working through?
Probably adenocarcinoma and a malignant epulis.
Yes, good. Yeah.
Mm.
Could it be a benign epulis?
No.
No?
Looks, I don't know. I don't know. Maybe it could. Radiographs would tell you.
I don't know that answer. I think I don't see enough cancer of any kind or dental masses like this. I think most of them are dealt with at GP. So I'm interested in your feedback as to whether that could be benign.
I always think like melanoma and squamous cell carcinoma.
Good.
I think like chondro and osteosarcomas are in there as well.
Absolutely. Yeah. There's one more round cell tumour I'd like to have on our list.
Lymphoma? Just put it on every list. But
yeah, you could, if it was a cat for sure.
Not thinking lymphoma.
Histiocytoma.
That's a really good point. I'm not sure if histiocytomas happen in the mouth. It's a... Have I used the wrong word? Is it not a round cell? That's weird. Maybe it's not. It's a tumour that happens everywhere. Usually cutaneous, can be subcutaneous.
Mast cell?
Mast cell, exactly. Is that a round cell?
Yeah.
Yeah. Okay. Yeah, so melanoma, squamous cell carcinoma are the two most common. According to the textbook, my experience in Australia is that probably carcinomas are as common, adenocarcinomas, I should say. And then fibrosarcomas, osteosarcomas, and mast cell tumors.
Yeah, fibrosarcoma.
Yeah, fibrosarcs. So fibrosarcs tend to be quite sort of like this, like big, but they tend to invade into the bone, and similar to osteosarcomas, which tend to be a little bit more diffuse, but they're very osteoinvasive. So when you see a mass like this, given that you kind of got those differentials in mind, how are you going to diagnose it, get a definitive diagnosis?
Excisional biopsy would be best, because you could relieve the immediate symptoms, and if it needs a larger resection, you've kind of got an answer.
I completely agree. Yeah. And if you've removed the kind of majority of the body of the tumour, then radiation might be more of an option, and things like that as well. So usually excisional biopsy, you're going to get your answer. What about if this was a cat? What tumours do we see in cats' mouths?
Squamous cell carcinoma.
By far the most common. And where do they, what's the most common location in a mouth to see a squamous cell in a cat?
I'm just trying to think, is it tonsillar? Or is that in dogs?
Tonsillar has a worse prognosis. So that's why the significance of squamous cells in dogs and cats, I think. Yes, tonsillar in cats also has a bad prognosis. But actually the most common location we see them is under the tongue. So when you do your oral exam in a conscious cat, it's really easy to miss them. So if a cat will let you look under its tongue, always worth a look. Excellent. So we've sort of, any questions about neoplasia? I mean, we could go into a deep dive on neoplasia, but probably not the time. I want to talk about a 8-year-old dog who presents with retching and gagging again, and tyolism. And I want you to, and on physical examination, the salivary glands are mildly enlarged, non-painful, just mildly enlarged. The clinical signs are progressive over the course of 2 to 3 weeks, and have not responded to an antibiotic trial with amoxiclav. What are your differentials?
It's bilateral, you said?
Bilateral, yeah.
Like a cyclosporine would be up there.
Yeah.
I don't remember the name of it, but there's an epileptiform thing that might cause this.
I'm so glad you said that. I love this disease. It's so interesting. It's called cyaladenosis. And histologically, there's no inflammation. Like the glands are enlarged, but they're actually quite normal. They're just a little bit edematous. So cyaladenitis and cyaladenosis are the two main differentials in this situation. The fact that it's bilaterally symmetrical, it almost takes like an ascending bacterial infection or something like that off the list, because you'd be really unlucky to get on both sides symmetrically. The key here, so most salivary disorders will result in tyolism, but the retching gagging is quite a specific sign for cyaladenosis as opposed to cyaladenitis. But I'd certainly want to document that there's no inflammation in the lymph node, in the salivary gland. So you could either do that with an FNA or TrueCut biopsy, or a surgical biopsy, but that's good. And then how do you treat, so no inflammation on our histone, how do you treat the cyaladenosis?
I'm going to guess steroids, but I have no idea.
There's no information. That's the interesting thing about it. So the steroids aren't going to do much.
Phenobarbital.
Yes.
Oh, yes, that's it.
It's so
I
interesting.
did read about that one.
Yeah. I've only seen that once in my career, and the dog responded so fast and so well to phenobarbital. It just got better straight away. And then we tried to wean it off. We thought, oh, don't want to commit this dog to pheno for the rest of its life. And it relapsed every time we weaned it.
Yeah, wow.
It was really cool.
Yeah, we had one in Wagga.
Yeah. Yeah, they're really interesting disease.
That's cool, isn't it?
Yeah, the biggest case series, I think, is like 13 dogs or something like that in the literature. But every single one of them, same pattern, couldn't wean them off phenobarbital and responded really quickly and predictably to phenobarbital. So as far as, this is a disease of excluding inflammation, but doing a phenobarbital treatment trial is very reasonable. And if they respond, you've got a diagnosis, essentially. Okay, what about we move into the esophagus?
I wonder how they figured that out.
I know.
Let's try phenobarb with that. Yeah.
It's such a clever person to have made that connection somehow, because I still can't get my head around the mechanism, and because nobody knows, like nobody's done the study on causality or anything, it just it's really remarkable. Okay, so this cat presents with weight loss, ravenous appetite, PUPD, and vomiting. What do you think about this radiograph, except we're not going to critique it?
It's quite a bit of gas in the stomach and gastrointestinal tract.
Yes, agreed.
How old is it? Is it young?
It's actually 11.
11.
It's real.
There's also gas in the esophagus or megaesophagus.
Did you say there is or there isn't?
I think. I can see the dorsal line of the esophagus kind of running through the thorax.
Me too, yeah.
I'm wondering, is there something in the stomach like a foreign body or a tumour? But the other thing that intrigues me is the ventral abdominal wall. It does appear to be intact. I was wondering if there'd been a car accident and some loss of integrity of those muscles, but it may just be a function of chronic distension.
Yeah, this cat looks like it's in poor muscle condition, I would say. There's not much muscle surrounding those femurs either. So let's talk about the esophagus, because that's our theme today. Megaesophagus in cats. What are the causes? Old cat. Sorry, segue away from the case for a second. What's the difference between a feline esophagus and a canine esophagus?
The distal third is made up of striated muscle, I think, or did I get the wrong way around? Smooth muscle? Yeah.
Good. The way I remember that, Josh, is that it's transitioning from a conscious muscle into the gastrointestinal muscle.
Right, okay.
So striated proximally, and then it turns into gastrointestinal tract.
Yeah.
And what are dogs?
They're all smooth the whole way down.
Yeah, exactly. Oh, sorry, all striated.
It's all striated. Oh, God.
Yeah, that down to something. And the only significance of that is the medications we can use, really, and the effect we're going to expect. Okay, so megaesophagus in cats. What's our differential list? This cat is unsedated.
I guess congenital or acquired, but unlikely to be congenital in a cat this age. Acquired can be neuromuscular junctionopathies, so things like myasthenia gravis, tic paralysis, botulism. Other causes can be polyneuropathies and intoxications as well.
Oh, we sort of did this.
Bled. I can't remember any others.
Chronic OP, I guess, but you'd expect
Okay, yeah.
signs and stuff. It's like, you know, with the esophagus affected in isolation, toxin's pretty low on the list.
Esophagitis.
Good.
Also, cats don't get poisoned very often. They're a lot more careful.
Much too smart.
I mean, in the country where I worked, there was a lot of organophosphate poisoning back in the day, but we never saw a cat with it.
Yeah, right.
Idiopathic as well would be another one.
Yes, good, excellent. Said esophagitis. What about foreign bodies?
Oh yeah.
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 The obstructive causes of megaesophagus. What about endocrine causes? What if I said this was a dog?
If it's a dog, I'd say hypothyroidism.
Good.
And hypo-A as well, hypoadrenocorticism.
Excellent. And what about if I said this is a cat on thyroid supplement, a cat on methimazole?
Oh, like maybe iatrogenic hypothyroidism?
Yeah, exactly. So I guess I wouldn't have it not on the list just because it's a cat. But I would have, obviously you know that in the history. And what about paraneoplastic? So that kind of fits into the neuropathy, myopathy thing. But certainly when we see a megaesophagus, I sort of think, oh, where's the cancer? Excellent. And then the only thing that's kind of really different between cats and dogs is that cats can actually get megaesophagus from pyloric outflow obstruction. Sort of radiographically evident. And Jeff was spot on in saying this cat has a massive hairball in its stomach. Like,
whoa, is that a hairball?
That's a hairball.
Oh my God.
This cat has pyloric outflow obstruction and a megaesophagus associated with that. Now, we didn't scope this dog, that went to surgery, so I don't know whether the mechanism of the megaesophagus in this cat was reflux esophagitis because of that sitting there all the time, or whether it was a purely mechanical megaesophagus, obstructive megaesophagus. But yeah, that's a pretty cool foreign body. Okay, so let's talk more about esophagitis, because I think it's kind of a hot topic. I just put that in because it's gross. Sorry. So this is a real patient. This is a 4-year-old Westie. Why did I say Westie? If you're going into a membership exam and you see a breed, specifically, not crossbreed, they're trying to get at something. Why did I say Westie?
Failed.
Westies get esophageal foreign bodies more than any other breed. So I think they've got some sort of esophageal dysmotility thing. So their strength of their esophagus just isn't as strong as other breeds, and they can't move stuff into their stomach as well as other breeds. So this dog ate sushi. That was a ball of rice sitting in its esophagus. Excuse me. Geez. It caused the most profound necrosis because it sat there. This dog was clinical for 9 days before the ball of rice doesn't show up on an x-ray, before it became clear that it had a foreign body. This is just obviously an incredibly extreme example of esophagitis. But what are the risks of this degree of inflammation in an esophagus? What do we need to kind of look out for in this dog?
Stricture.
Absolutely. And what are the features of this inflammation that makes us think this dog's going to stricture? Or
it's circumferential.
Exactly. Yeah. So if you've got a round structure and you've got inflammation through the whole circumference of that, then it's going to fibrose down as it heals. So you're really likely to get a really diffuse narrowing. Whereas in the times when we see esophageal foreign bodies, or for that matter, reflux under GA or something like that, often the inflammation isn't circumferential, it's just in sort of 3 points where a bone was kind of poking at the esophagus, or the reflux sat in the ventral portion of the esophagus. And the esophagus was otherwise kind of flaccid and dilated and wasn't as affected by the reflux. So when it's been full circle like that, stenosis is a real consideration. So talking about reflux as one of the causes of esophagitis, what are the risk factors?
General reflux in any pet.
Mm.
I'm so glad we're talking about this because there's very little written up about it, and I've seen a couple of cases, but I don't.
Yeah. What's a really interesting phenomenon, because they've done all these studies trying to work out why it happens. Someone give me a little bit of a, like what are the risk factors for it?
Brachiocephalics.
Good. Excellent. Why?
They have changes with their kind of pressures in their body. So because they're so narrow up here, they have to increase the negative pressure in their thorax to try and bring air down and inflate their lungs. So that negative pressure is more likely to cause things like reflux from the stomach back into the esophagus, is my understanding. And also they're more prone to having hiatal hernias, those kind of things.
Good, excellent. Yeah, so they're the main two things. That's awesome. So when a brachycephalic dog breathes in, they have to create more of a vacuum in their thorax to draw the same amount of air in. And the result of that, when you've got a vacuum next to the stomach, is it's either going to suck the stomach into the esophageal hiatus and create a hiatal hernia, or it's going to suck the contents of the stomach into the esophagus and create reflux. So brachycephalics, this is an emerging problem, this kind of airway / gastrointestinal syndrome that we're seeing in brachycephalics. So that's one brachycephalics risk factor. What about an iatrogenic risk factor?
Like nonsteroidals, maybe?
I don't know, there are some medications associated, like if we've got direct kind of chemical to the esophagus.
Like doxycycline and clindamycin.
Excellent, yeah. And then what about, in what situation do we cause esophagitis most commonly in a vet clinic?
GA.
Good, yeah, that's the classic one, isn't it? The regurgitation, the reflux under GA. So one of the risk factors for esophageal stricture is having had a GA in the prior 3 months. So just that little bit of reflux in some situations does absolutely nothing to the esophagus, and in other situations causes esophagitis, and they don't know why it happens in some patients and not the others. There's done experiments where they've bathed esophageal mucosa in the pepsin and acid that comes from the stomach. So it's not just the acid burn, it's the actual protein digestive enzymes that come from the stomach into the esophagus, and they bathe the esophageal mucosa in it, and it doesn't actually cause burning. That's what the esophagus is designed to sustain. So it's to do with perfusion, it's to do with blood pressure, it's to do with time, volume, and how much the kind of fluid moved around, you know, if it's just sitting there for a really prolonged period of time versus if it's kind of, the dog's kind of moved quite rapidly and it can flow back down into the stomach. So what, does anyone know, GA is a risk factor, but do you know when in a GA a dog refluxes and when the risk factor times are? It's actually moving. So you're better off to induce your patient in the room that's going to have surgery in and just roll it over, because we carry our patients, we put pressure on their stomach and we carry them, and their stomach juices just flow up into the esophagus. So going from induction to surgery room, but also surgery to radiology is the risk times for reflux. So if you're minimizing movement under GA or moving in a way like on a wheelie table, and sliding the patient across onto the radiology table rather than picking them up, you're going to minimize risk of iatrogenic.
Wow. So just reducing extra intra-abdominal pressure.
Exactly. Yeah.
Wow, they're so valuable to know.
Yeah, I think so. And there's not, I mean, we don't have enough data to say, you know, if you do these, you're going to have decreased incidence of esophagitis. But I think the risk of aspiration with reflux events and stuff, you know, it's so shocking when a dog vomits under anaesthetic, isn't it? It's just your heart goes into your mouth. You're going to decrease risk of that using these same techniques and decrease your risk of esophagitis as well. So that's just, yeah, little pointer.
Can I ask you about general reflux esophagitis? Because I've seen it, if we have time, 2 dogs. One a few years ago, a miniature Foxy, and one this year, a Pomeranian. And I never got confirmation it was reflux esophagitis. It was just evidence of discomfort after a meal, after a meal. And I treated them with, I think, Caraphate slurry and Losec for a few weeks, and it resolved, but I never got confirmation. I don't know if it was right. I don't know what the risks were, and I don't know what the correct treatment is. And I find it very hard to find information about that. Is it actually a thing?
Yeah, it absolutely is, for sure. And the leading symptom of it is exactly what you described, that discomfort after eating, which usually manifests, it's called, I don't actually know, this is one of those words that I've read a million times, but I've never actually heard anyone pronounce it. So if anyone knows how to say this, it's Oesophageal. Is that right? Yes. Oesophageal. So after eating, that neck stretching and just pausing after eating. We see it a lot in Brachiocephalics, I find. They eat their meal and then they just stand there for a minute, and they're trying to like shake their stomach out of their thorax. Maybe not, but it's very dramatic. The treatment for esophagitis, there's no consensus on it. So you ask a specialist, you're going to get a different answer. So the theory is that you use Losec to minimize the acidity, which gives that a chance to heal. In a dog that's got chronic reflux, it gives the inflammation a chance to heal, because if you've already got mucosal disruption and you've got acid reflux hitting that, it's just not going to heal. So the Losec helps with that, and that's pretty agreed on across specialists that I've read their opinions. The Caraphate, they say that the Caraphate is activated by being in an acidic environment. So it doesn't actually get activated till it's in the stomach. So a lot of people say it's not going to help with esophagitis, but we're trying to protect the esophagus from what's coming out of the stomach. So I would argue that it's very worth giving Caraphate. And the other argument I make for Caraphate is humans use it with tonsillectomies.
Oh.
Because it provides, even though it's not activated yet, it provides a coating, and anecdotally and data-wise from human patients, we know that in the very proximal, without the presence of acid, it provides pain relief due to the coating it creates on the surface of the tonsils. And therefore, I think we can probably extrapolate from that and say it's quite safe. And if we're giving it in a slurry form, it's probably going to provide some pain relief, keep the patient eating, and keep things moving through. So yeah, I think what you did is perfect.
You wouldn't add anything else to that?
No.
No other magical cure. And do the humans for tonsillitis do it as a slurry as well?
Yep, exactly.
Interesting that it's available as tablets if we're always using it as a slurry, even in people.
I know, I don't know why. Yeah, they give it as a slurry when they're trying to use it for that indication, but when they're using it for gastric ulceration, they use it as tablets.
Oh, okay, cool. Yeah. Thank you.
No worries. All right, we might wrap up. Thank you everybody for coming. And I think the next one's in a fortnight, and I think we're doing host microbiome interactions, which is such a booming area. So it should be an interesting conversation. But if you've got any questions about probiotic use, antibiotic use, and stuff like that around, and how that impacts the host, then either send them through beforehand or bring them and we can chat about them next time.
Thank you.
Awesome. Thank you so much.
Yeah.
Thanks, Anna.
Thank you so much, Anna.
So valuable to what we learned.